Hello and welcome to the second of the APACI Webinar Series on the use of antivirals for influenza. Our topic this evening is pandemic planning. This program is hosted by Praxhub and presented by the Asia Pacific Alliance for the Control of Influenza. It's intended for health professionals to update you on various aspects around antiviral use. My name is David Smith. I'm a clinical virology at Pathwest Laboratory Medicine in Western Australia. I'm also a clinical professor in the School of Medicine at the University of Western Australia. And I'll be your facilitator this evening. Presenting at tonight's meeting, we have Professor Paul Tambyah, who's based in Singapore, and Associate Professor Lance Jennings, who's a clinical virologist in Christchurch, and he's director of the WHO National Measles Laboratory there. Lance, many of you will know Lance for his many visits to everywhere in the region. And he serves on a number of government committees within New Zealand and has served on a number of organisations in the region. And he was past chair of the International Society for Influenza and Other Respiratory Viruses. So I'd like to invite Lance to speak to us now on pandemic planning. Thank you, Lance.
Thank you very much, David, for that very kind introduction. And I'm largely retired at this point in time. However, I would like to talk about pandemic planning tonight, and the primary purpose for having a pandemic plan is essentially to flatten the epidemic curve. And so that we can minimize the impact of a disease, should it be influenza, a novel influenza virus, moving about communities, minimize the social disruption, and minimize the economic consequences of a pandemic. And this particular example here is relates to the health system and minimizing the impact on our health system. So that's the primary purpose of pandemic preparedness planning. What I would like to do this evening in the next 30 minutes is to talk about New Zealand's approach to pandemic preparedness planning. We had our first plan in place in 1997 when the World Health Organization had its first plan in place. And talk about how the plan has been tested and updated and how we've maintained it as a living document since this time. And then relate to some of the lessons that we've learned from using the plan in response to the SARS outbreak and the more recent 2009 H1N1 outbreak, and then finish with the use of the plan in the current response to the COVID-19 pandemic. Our framework for action is sets out all of government measures to be taken to prepare and respond to an influenza pandemic. And this plan, the current version is 2017, and it was due to be updated this year, but of course COVID-19 has taken over. The plan is intended for anyone in New Zealand involved in planning, preparation, or responding to an influenza pandemic. But it also provides general information on pandemics for and government planning for the New Zealand public as a whole. So the New Zealand pandemic plan fits alongside and within the National Civil Defence Emergency Planning Systems, the National Health Emergency Plan, and all the regional emergency plans, which filter right down to the hospitals, primary care, public health, community providers, and other services. And the goals of this plan are threefold, relating to human, social, and economic issues. Firstly, minimizing the impact of the disease and mitigating its effects on the people of New Zealand without increasing health inequalities. And socially, to enable the society to continue to function as normally as possible during and after a pandemic, and to minimize and mitigate the economic consequences of a pandemic on New Zealand. There are a number of phases with our plan, and currently the initial phase is planning phase, but once a novel virus enters the community, we try and keep it out and stamp it out, eradicate it, and once that's impossible, manage it, move to the management phase, and then move on to recovering from it once it passes over. So the plan is coordinated, the communications and information sharing is coordinated, and this filters right down to regional and local plans. Our first preparedness plan, as I've already mentioned, is at the same time, was in place about the same time as we had the H5N1 outbreak in Hong Kong, and WHO had its first pandemic plan. We first tested the plan in exercise virus in 2002, and we were the first country globally to test have a national test of our pandemic plan. Then it was updated. The plan was used for responding to the SARS outbreak in 2002, 2004. And one of the important lessons we learned at that stage was the importance of government in responding to an outbreak. We approached the government at that stage to have the ability to close our borders. And the government at that time, we were a just-in-time society in many aspects of our supplies and of course tourism, and the government did not have the appetite to want to close the borders at that time. So that was a very important lesson from that outbreak. The plan was then used in 2004 to respond to avian influenza, and then in 2009, the H1N1 pandemic. And of course, the current response. What is interesting about the plan, the SARS outbreak in 2002, 2004, the plan and response to it was largely delivered, directed by virologists and public health folk, and progressively government, Ministry of Health and government have become more involved. So in 2009, we saw government directing the response to the pandemic. And of course, as I'll explain later on, the Prime Minister and Director General of Health have led all the responses to the current COVID-19 pandemic. Under the plan, advanced purchase agreements for specific pandemic vaccines have been put in place. And of course, the stockpiling of vaccination supplies, syringes, etc., stockpiling of antiviral medication, both Tamiflu and Relenza, and stockpiling of masks and other personal protective equipment. Antibiotics, ensuring reserves of PPE are all distributed throughout the country, and so on. So a lot of pandemic planning deals with having reserves and supplies. Now, referring to the H1N1 PDM 2009 response, the virus was first introduced into New Zealand on Air New Zealand 1, a group of school children returning from Mexico on the 25th of April 2009, shown on the left-hand side there. And 5 days later, the influenza AH1N1 was declared a notifiable disease, and the pandemic plan was activated, and we moved to try to the containment phase to try and stamp the virus out. And this we successfully did for about 6 weeks. We kept the virus out from circulating in New Zealand until early June, when it was introduced by people returning from Australia into New Zealand, and community transmission started to occur. That 6-week period, the stamp it out period, was extremely important because it allowed consistent public messaging to be got out. Educating people about hand hygiene. Hand hygiene was focused on for influenza at that stage, simply because people understand the importance of washing hands and for transmitting disease in general, although it may not be quite so important for the transmission of influenza and other respiratory viruses. So cough etiquette, which wasn't common at that stage, was woven into this messaging, and also community resilience, the importance of having food and water and essential supplies at home in case you have to look after yourself. So there are a number of lessons learned from this outbreak, which have been woven into our pandemic plan. And one of the important lessons was the importance of laboratory diagnostics and the escalation of the workload in the laboratory and managing to that. So following that escalation pathways were introduced into our laboratory systems. The lessons learned from the 2009 pandemic. One of the important lessons for New Zealand was border control and international travel restrictions, we believe have potential in island nations. And this is contrary to WHO's guidance. And this is one of the reasons I believe that a lot of attention has not been paid to it. We had experienced the 1918 pandemic in New Zealand and the Pacific Islands, which was documented by McLeod and in 2009. And in this graph here, we've got the attributable death rate on the left-hand axis here, and on the lower axis here, the date of arrival of pandemic influenza in a number of countries. And you can see these blue squares here are countries which had strict maritime quarantine, All the ships had to sit offshore for 2 weeks before entry could occur. And you can see here that the countries, Australia, entry of the virus was delayed until the end of February, March 1990, Tasmania, September 1919, American Samoa, 1920, and New Caledonia into 1921. And what is important is right next door to American Samoa is Western Samoa. And these two countries are a little more than a stone's throw apart, but American Samoa had strict quarantine and the virus was delayed, and when it entered in 20, no deaths occurred, whereas quarantine was broken by the Tulane ship from New Zealand into Western Samoa, and an extremely high mortality rate there. Over nearly 25% of the population died. So maritime quarantine appeared to protect South Pacific Islands from the 1918-19 influenza pandemic. That was a very important paper. Since that time, modelling of border control and border closure in New Zealand has been carried out, and these have been found to be both cost-effective and cost-saving. Another lesson, the need to enhance strategies to reduce future impact of ethnic health inequalities. Our Indigenous population are more susceptible to influenza in New Zealand. And so we need to put greater focus on reducing chronic disease burden in the country with and obesity, address crowding through improved housing, and really reducing poverty is the bottom line there. We need to enhance public health capacity in the New Zealand health sector. Public health units are involved in contract tracing, as we're finding with this current COVID-19 outbreak, because these events, pandemics, and this is the 1918 pandemic, showing that rapid increase in the number of cases. Laboratory capacity and surge capacity within laboratories is extremely important, as I've already mentioned, and the importance of surveillance, of knowing where the virus is in the community and who's being affected. And the importance of ongoing and exercises simulation exercises to keep your plan as up to date as possible. And the need to enhance social capital, linking these exercises and planning to other civil defence preparations, supporting the use of smartphones by everyone and access to the internet, which in smartphones has become extremely important in this current outbreak for contact tracing, and supporting influenza awareness initiatives. And in that context, the importance of one of the focus of APACI has been on the need for robust seasonal influenza awareness programs in our region, as they are critical to a nation's and a region's ability to respond to a pandemic as quickly as possible. And I'd just like to briefly relate some of our Canterbury, New Zealand primary care initiatives, which focuses on the importance of intelligence and surveillance data feeding into your immunization strategy for seasonal influenza. And building the capacity of practices, both pharmacies and facilities within your particular primary care sector, so that they're all prepared in advance, with the ultimate aim of protecting your secondary care services and keeping people out of hospital. And this is a key to sustainability. So the primary care workforce is the key to sustainability of any influenza control strategy. And when we look at the triggers in general practice, level 1 for an average season, and the management of general practice patients, having patients phone in or visit if they're unwell, and having safe waiting room protocols. Then when the season gets a bit busier, epidemic takes off, having patients phone in if they're unwell, and the practices having safe waiting room protocols for streaming of these patients. And then when you have an exceptional seasonal pandemic, then having all of these, but perhaps in addition having designated clinics and fever clinics or flu clinics for directing your patients to. So having a defined escalation pathway is important. And the reason for this is here's the normal workload during the season for a primary care practitioner. And then with increased ILI and respiratory illness activity during the winter, and if there's which puts pressure on the practice capacity during the winter season. And then if there's an exceptional season or a pandemic, at the same time, it puts pressure on your practice capacity. You also have staff who are sick. So planning is just so important in advance. And this slide simply shows the importance with the Canterbury initiative of green streaming and red streaming patients. Red streaming being those with respiratory illnesses. And as the response options are for sending these respiratory illness patients to a separate clinic, and the green, so you're separating the green stream, the red stream, and then having as escalation pathway and pandemic increases, then having centralized response with perhaps fever clinics or dealing with all the patients with acute respiratory illness. But pivotal to this is knowing what's going on in the community. Influenza surveillance. Intelligence is pivotal to ongoing influenza awareness education in the community. And the Canterbury GPs do this by weekly sending out the single pager of information to every GP, which has both the hospital statistics and the community statistics of all the respiratory viruses and hospital admissions that are occurring. Now, just to finish off on, I'd like to talk about our New Zealand response to the COVID-19 2020 pandemic. And rather than having a stamp it out strategy, the government had decided to move to an elimination strategy. From the experience in China, they decided that it was, and because we're an island nation, they decided it was possible to eliminate the virus totally from New Zealand. So they've introduced a new set of alert levels, which and numbered 1 through 4, with 4 the highest level involving total lockdown of the country. Now, before I itemize some of the responses that were put in place, this is a curve of the confirmed, daily confirmed and probable cases by source, and the blue relates to imported cases, and then the orange color are the locally acquired cases. So you can see with the introduction of the virus, first case was identified on the 28th of February. And then through March, we had an increasing number of cases along with community transmission. The elimination strategy and lockdown, we managed to control the spread of the virus. And then most of the cases, apart from an outbreak of community transmission in the Auckland region in August and early September, these are largely imported cases that are controlled at our borders. So our response from the 16th of March, we introduced border restrictions involving compulsory self-isolation of people and cruise ships prohibited from New Zealand. And then on the 19th of March, the border was closed to all but New Zealand citizens and residents. It's interesting that we were an early country to put border restrictions in. We probably should have done it 2 weeks earlier than what we did, but it's the government's prerogative to sound out the mood of the country. Until President Trump closed the air traffic between the United States and Europe, this was really, border closure was a tricky issue in New Zealand. But once that had happened, it became acceptable, and the government could close our borders to all but New Zealand citizens. Then very rapidly we moved into a lockdown situation where only essential workers were out, and everyone sort of stayed at home over a 5-week period. So and during this period, the virus was eliminated from New Zealand. Pivotal to this strategy was contact tracing and, of course, laboratory testing. And this curve here just shows the number of tests that have been performed, and you can see the escalation of the number of tests being performed. Earlier on, the number of tests were probably minimal, simply because the case definitions had travel as the primary focus of the case definition for a COVID-19 case. And then the subsequent following slides just show the same epidemic curve with some of the national responses and the measures that were put in place. The border control measures, banning arrivals from some regions initially occurred from February, and then banning non-citizen arrivals from all regions, and banning cruise ships were introduced in March and still in place, and placing incoming travellers into self-isolation or quarantine for 14 days. Then was introduced a little further on, and then requiring testing at days 3 and days 12 for all people in quarantine was introduced more recently. The other community transmission control measures were put in place around lockdown with regard to cancelling public events, etc., which are standard for most countries. Then case-based control measures, extensive contact tracing is still going on, and testing of people in the community with respiratory symptoms occurred at the end of lockdown. And extensive testing was introduced, and then screening of asymptomatic people in selected populations and workplace was also carried on. And finally, the health and well-being and economic support. The government put in a credible package supporting people who were because of particularly the tourism sector, who had no income. So there's a lot of support in the workplace. An early immunisation vaccination program was instituted, and coordinated public information campaign was introduced. So New Zealand is currently in level 1. Effectively, level 1 means that you stay at home if you're sick, and contact the health line, one of the health lines, or your GP, and get tested. Use the contact tracer, so the importance of contact tracing. The government has supplied a contact tracer on people's cell phones. The downside of that is not everyone has cell phones, and we haven't taken the next step of moving towards a dedicated contact tracer card, which some countries have introduced, and wearing a face mask. And that's been an interesting transition in New Zealand, and face masks are now as pivotal or required on all flights and public transport in the Auckland region, and for all flights nationally, masks must be worn. So really, it's been a learning experience. New Zealand has used the Swiss cheese approach with ongoing review of all the clusters of infection, with the introduction of additional public health measures. And as I just mentioned, the latest public health requirement introduced by the government is the wearing of masks on public transport. Pivotal, though, has been the messaging. Leadership has been from the top, with our Prime Minister and Director General of Health being on television daily at 2 p.m. With a consistent public messaging. The concept of bubble, remaining in your bubble during this period, was something that was conceived in New Zealand and promoted widely, and is something that is well understood with regard to trying to interrupt the transmission of this virus within the community. And the supply of real-time statistics, or the number of cases occurring in New Zealand, and where they're coming from, or where they were, led to transparency, government transparency of this outbreak. So at the end of it, really, we have a team of 5,000 in New Zealand, a team of 5 million, because the leadership was from the top. So in conclusion, where do we go from here? What shape is the next pandemic going to look like? And I don't think we know when the next pandemic is going to occur or what it's going to look like. This one probably came out of the left field, but it's important that we learn from the lessons of COVID-19 and that we ensure that our pandemic plans are updated once we manage to control the current pandemic. Thank you.
And thank you very much, Lance, for that wonderful presentation. Please, we will be taking questions and discussion around both talks after the next presentation, so prepare yourselves. So it is my pleasure to introduce Paul Tambyah as our second speaker for this evening. Paul is a professor of infectious diseases. He's at the National University of Singapore, and he's also a politician and a writer, multi-talented. He will be well known to many of you in the region, both, and he's been a leader of a number of organisations in infectious diseases within Singapore, and now has taken on the role of president-elect of the International Society for Influenza and Other Respiratory Viruses. So welcome you, and thank you, Paul, to do your presentation.
Thank you very much. I'm going to share with you some lessons that we learned from responding to this particular pandemic. But again, as most of you would know, Singapore is probably the opposite of New Zealand in that we're an extremely globally connected city. And as a result of which we've been affected by every pandemic that's occurred, at least as far as well-documented recorded history from the 1918 pandemic. We had a very detailed pandemic plan that was put in place in April 2014. But as I'm going to mention, as you probably know, it's a famous military quotation that no plan survives the first bullet. So I'm actually particularly guilty of this. One of the things that I have, in addition to the university appointment, is an appointment at the National Center for Infectious Diseases. And we give out small grants. So in January of the year, this year, we gave out a grant for a short-term fellowship to a scientist who was going to the Wuhan Institute of Virology. And she wrote to us at the end of January, and she said, due to the emerging virus burst in Wuhan spreading all over China, I'm going to cancel my February trip. I managed to cancel my hotel and other bookings. However, the budget airline refused to reimburse my ticket. Can I still reimburse it? And to my eternal shame, I wrote to her on the 22nd of January, we should try to reimburse if she can provide documentation she was told not to go. If she's just scared of getting pneumonia, we shouldn't reimburse her. And of course, you know, the rest is history. There's millions of people who've been infected and more than 1 million deaths as of this week. Now, one of those cases is a patient of ours. This is a 72-year-old woman with mild diabetes. She felt unwell, but went out with her friends to the market, became drowsy on returning home, collapsed in the ambulance, was resuscitated, intubated, had a CT scan at the emergency department, which showed a massive intracranial bleed. She was terminally extubated, but an alert emergency department took a look at her chest x-ray. Said, this doesn't look like somebody who was aspirated or had an intracranial bleed. So called me up and said, should we do a PCR, COVID PCR? And we did, and true enough, it turned out positive. We took a sample from her blood after she passed away and also came back positive for SARS-CoV. So she was reported in the media, but she wasn't actually counted as a COVID death because Singapore rigidly adheres to the original WHO definition of COVID deaths being pneumonia deaths as determined by the treating or certifying physician. Bottom line though, is that mortality from COVID is primarily age dependent everywhere. So Singapore's age-specific mortality rate in 80-year-olds is 20%, which is very similar to what it is in South Korea, Spain, China, and Italy. And so the first lesson I think we learned from the pandemic, which most of you know anyway, is that older people are at risk, which occurs in most pandemics. The second thing that happened in this pandemic was there was lots of modeling. Some of our modelers got their papers published in the Lancet and other journals like that. And there was all kinds of estimates as to the impact of the pandemic. Now, you know, the last pandemic, which Lance mentioned earlier, seemed to have been a long time ago. But there was an interesting comment that was made by Margaret Chan about 2 months into the pandemic, where she said this pandemic cannot be stopped. And she said that, you know, even though she said majority of cases were mild, not life-threatening, most sufferers would recover within a week, but there was still a high risk for pregnant women and those with existing health problems. She said young people are dying who are perfectly healthy, and the result of which was, of course, the end of the containment approach and a mitigation approach to the pandemic. And this chart shows the number of modeling papers of the 2009 pandemic. And you can see they shot up all the way through October 2009 before finally leveling off. And as they say, all models are wrong. It's just that some are less wrong than others. And we've seen the impact of models on various policies all over the world, not just in Singapore. The third point I'd like to highlight is that at the beginning of the pandemic, we used a very strict containment approach in Singapore. Every case was carefully contact traced with active case finding, containment of spread at the individual level. And this allowed us, at least for the first couple of months, to go by without physical distancing, business closures, or lockdowns. And this was very thorough epidemiology, close investigations using closed circuit TV, electronic means, and all kinds of approaches, which allowed us to identify the first few clusters of SARS-CoV-2. In fact, this is a clear illustration. It was reported in the Lancet, where there were two individuals who were infected and they couldn't figure out what was the connection. And then they realized that there were two individuals from China who were not church members, who attended a church service, did not report having lunch at the church or any contact with anyone else in the church. However, they occupied the same seat as someone who was subsequently infected. And this was not just based on recall, it was based on closed circuit TV in the church itself. Don't ask me why they have closed circuit TV in church. Maybe people are helping themselves to the offering bag. But ultimately, they tracked down 191 church members and found 6 of them unwell. None of them tested positive. So, you know, if this virus is airborne, this is probably the least effective airborne transmitted virus that there is. But there's an intriguing possibility about individuals, no contact, but occupying the same seat. So initially, Singapore had no lockdowns. This was highly successful. However, unfortunately, this was not the case later on. So early on, when you've got relatively small numbers, you've got a well-developed infrastructure, containment can work. Now what happened, of course, is that the data has been evolving. And this is, you know, fueled a lot of conspiracy theories. And I'm sure you've seen some of these videos that have been going around about the pandemic. And but basically, I like this comment. See, he says, by changing your mind based on new evidence is a badge of honor in the scientific community. And in fact, the latest publication to come out about in the last week is the Denmark study published in the Annals of Internal Medicine, which showed essentially that there was no difference in terms of acquisition of SARS-CoV-2, whether you wore a mask in addition to social distancing or you didn't. So the data keeps evolving. And this is one of my pet peeves, is that there is widely held belief in the miasma theory, which reigned in clinical medicine from the time of Hippocrates to Louis Pasteur. And this is fueled in this particular pandemic by papers such as this by Van Dormelen, published in the New England Journal, showing the persistence of live virus in aerosols up to 3 hours after it was dispersed. Now, what I always tell my students is you have to read the fine print. So if you read the supplementary appendix, you'll realize that this was a high concentration of virus in a high-powered nebulizer delivered into a special chamber used for identifying bioterrorism agents. So in a highly controlled laboratory setting, I do agree the virus can be airborne for a prolonged period of time. In contrast, in real life, in Singapore, at the National Center for Infectious Diseases, air samples were negative despite widespread environmental contamination in patient rooms, in chairs, on stethoscopes, on the sinks, in toilets, all over the place, basically in patient rooms, except in the air. The group from the University of Nebraska, which helped us build negative pressure isolation rooms in our National Center for Infectious Diseases, found samples which were positive for viral RNA by PCR. However, when they tested them for cultures, they were all negative. They were unable to culture virus despite high copy numbers in certain parts of patient rooms with the coronavirus. And finally, this study from the University of Florida was published allegedly showing live virus some distance away from the patient. But what is intriguing is that this patient, who was well and about to be discharged, was not found to be positive for the virus, but his air samples were positive, and nobody knows where those positive viral cultures came from. So this is an issue, and you may have read that 239 scientists wrote an open letter criticizing the WHO. And I like to think that, I was actually supposed to be the 240th, and Julian Tang, who some of you know, wrote to me and asked me whether I would sign on to the letter, but I refused because I don't believe in airborne transmission, aerosol transmission in most settings, unless there are aerosol generating procedures. And this has, of course, led to the WHO and CDC being in the firing line, as there's this huge controversy about this. And this was an issue even in 2009, where some of you know there was a large study published from China, or rather published in the media from China, suggesting that N95 respirators were better than surgical masks in terms of preventing H1N1 2009. I was at IDSA when the paper was actually withdrawn. And the head of IDSA, Shea, and APIC actually wrote to President Obama, who I'm sure had a lot of other more important things to think about. But that's how emotional people got to and this whole issue of aerosol transmission of H1N1. So during SARS, N95 respirators and FFPs were widely available. Even bank robbers used them to rob a bank. However, they were uncomfortable, and this guy put it on top of his head, and he got caught in the security camera. Fortunately, post H1N1 2009, surgical masks now dominate, even in the bank robbing environment. And so this is a guy who was using a surgical mask to rob a SingPost branch. So during 2009 influenza A, I firmly believed that you only needed a surgical mask. However, when I tried doing this during COVID, I was told off by everybody and forced to use an N95 when looking after patients with COVID. So the lessons are that, again, science should guide policy. This is problematic if there is a consensus. And so this is where good communications are critically important. And I think all of us have learned a lot from New Zealand on how the policymakers can take the science and make the policy decision and communicate it effectively. Next point, like SARS, SARS-CoV-2 is not easily spread by most people. In fact, most cases in Singapore, when we did these detailed investigations, were only associated with 1 or 2 secondary cases. But you have a handful of individuals in the long tail, the so-called super spreaders. In Taiwan, we find that most transmission occurred in households. Now, the same was found in India in this huge study of 575,000 contacts with 84,000 infected individuals. The vast majority of transmissions occurred in households with a few super spreading events that occurred. Now, I know I dissed modelers earlier on, but some of my best friends are modelers. And this is a study that they did, which suggested that actually when you have stay-at-home orders, household transmission becomes the key means of transmission. And this is a huge issue when you've got large households, such as dense migrant worker dormitories in Singapore. And this was written in March. So what happened in Singapore is we had this really good containment early on in the outbreak, and then we had massive outbreaks in the migrant worker dormitories where you've got 15 to 20 people sharing a room, and up to 100 people sharing a set of bathrooms. And that put a huge strain on the system. So the decision was taken to move the care out to the dormitories. Screening was performed by a primary care team without chest x-rays or point of care testing, just depending on clinical features alone. There were some unintended consequences of attempts to preserve the healthcare system, where the Ministry of Manpower issued an advisory telling employers not to send their workers to hospital unless there were a medical emergency, resulting in ongoing transmission in the dormitories. And this is what was known as the Diamond Princess strategy, where you try and protect the general public, but unfortunately there's going to be continued transmission in the closed setting of a crowded dormitory. So there were extraordinarily high attack rates. The same group screened 5,977 workers in one dormitory. 1,800 of them were symptomatic. Of them, 69% of them were found to be positive. This is on a single swab. So it's really one of the world's highest attack rates, and it's inevitable in a crowded dormitory setting. And the same has been seen in many other parts of the world. It's happening right now in Malaysia among migrant workers in factories. So we had segmented epidemiology reporting where we had imported cases in the tens, community transmission again in the tens, whereas migrant worker cases were in the hundreds, occasionally reaching up to 1,000 cases a day. And this unveiled a pandemic of inequality. where, as you know, Singapore in general is a relatively wealthy city, but we have these marginalized groups. So what a group of us did was to try and see if we could do something, and we ran a prophylaxis study, which we're in the process of analyzing the results of. The mental health impact of this on the migrant workers was significant. We had a couple of suicides and significant stress in these individuals who are living in these very crowded environments. A number of them were actually clinically depressed or had pre-depression kind of symptoms that were seen at the time. So I think the fifth and probably one of the most important lessons that we have learned is that the marginalized are at high risk, and this applies to any epidemic or pandemic, and it was particularly so in a respiratory viral pandemic, which is transmitted most efficiently in households with very close contacts. Now, finally, I'm going to branch off a little bit and point out that when our public health people looked at the national data, they found that with the COVID pandemic, the number of clinic visits for acute respiratory infection dropped, partly because people are afraid of getting quarantined, but the influenza positivity plummeted by March of 2020. There was hardly any influenza at all, March or April, and in fact, we have sentinel surveillance in primary healthcare clinics, and we haven't had influenza at all since May. Taiwan has reported a similar experience, and you can see that the visits for ILI diagnosis dropped off, they've leveled off after a while. Influenza has completely disappeared. In contrast, varicella, which is a truly airborne virus, hasn't changed at all. And you know, they wear a lot of surgical masks in Taiwan. That's not going to protect you from varicella. So varicella is still the same, influenza disappeared. And that's the Taiwanese experience. And in Australia, there's been the lowest overall death rate for years in the last few weeks, as far as I could find from the Australian Bureau of Statistics. And this is highly significant. You know, we were interviewing an Australian ethics professor, and I asked him this question: if it's true that, you know, we have 200 to 300 fewer deaths a week with all these drastic conditions, can we ever go back to the pre-COVID? And I'd like to ask all of you this question. You know, we don't know which actually worked. Banning people traveling, putting in all these mask practices, you know, whatever it is, it seems to have worked. You've had 100 to 200 fewer people dying every week. Okay, yeah, so, oh my goodness, the majority feel we should do some kind of enhanced mask use or social distancing forever, but nobody wants to keep the current restrictions forever, thank goodness for that. So anyway, so the disappearance of flu in Australia is very striking. Influenza and pneumonia deaths have been way below average. However, cancer deaths have been unchanged during this year. And the same has occurred all over the world. So this is 2020 data from the WHO. You've only had a handful of cases of influenza from isolated areas. And this is in contrast to the same week in 2015, for example, where you've had significant amounts of influenza all over the world. And it's occurred in both hemispheres. In the Northern Hemisphere, complete disappearance of influenza. Southern Hemisphere, just a few sporadic cases here and there. So the million-dollar question, what and when will the next pandemic be? You think it'll be H1 in 2022, H3 in 2021, H2 in 2021, H5 in 2021, some other influenza virus some other time, or another coronavirus anytime? So some other influenza virus some other time, oh no, that's not very encouraging. My bet is on H2 though, but I see that only 2 other people agree with me. So basically, I think in terms of pandemic planning, there's this famous quotation from Clausewitz, the great military scholar. And he said the world has a way of undermining complex plans. This is particularly true in fast-moving environments. A fast-moving environment can evolve more quickly than a complex plan can be adapted to it. By the time you have adapted, the target has changed. But that's not a reason not to plan. In fact, as we plan, we have so many scenarios, and the very act of planning, you know, it brings together the people that you never knew existed. You know, people who have, we find PCR machines all over the place. You find BSL-3 laboratories all over the place. You find people who can do good epidemiology. And all of that helps in preparing for the unknown. So my final slide, I'm going to say, is that we ultimately, we lived in a globalized world. Most of us haven't traveled for the last 10 months or 8 months. And ultimately, nobody is truly safe until everyone is truly safe. And I think that's what we've got to take into account when we do our planning for the next pandemic. Thank you.
Thank you, Paul. Right, we're all here now. Yeah, thank you, Paul. That was great, and another thought-provoking presentation. So, can I ask, well, to Lance Primera initially, but feel free to chip in, Paul. You talked about what we do as a pandemic plan and how we respond in different stages. Does everybody have to do the same thing? Did you do that in New Zealand as a national thing? All of you did the same thing? Or was it tailored to different areas? And is there a danger in doing that?
No, it's a good question, David. It was a national response. And hence in my final slide, it was a team of 5 million response to control the first spread of the virus in New Zealand. It was national lockdown. Obviously, it was good enough for us to be able to eliminate the virus. And obviously there were a number of people that didn't honor their obligations and did move about. But by and large, it achieved the objectives of the Ministry of Health in terms of elimination of the virus. With regard to, but I think we're fortunate because we're an island nation and with 5 million people. And so its communication's a lot easier. And also the country is reasonably spread out. So the main population centres are well separated. So I think with public transport diminishing, well then it's probably easier to restrict clusters of disease occurring. Larger countries, and I'm really impressed with what you've managed to do in Australia, David, and with the border management and the states closing the borders and restricting movement of people. So obviously, even though you are an island nation, but a pretty large island in that respect, it clearly shows that restricting people, keeping people in their own bubbles, social distancing does work for controlling this virus.
Yes, certainly it has been successful for that. Indeed, it was a lesson we learned from 2009, where it was clear that doing everything at the same time wasn't appropriate for some of the jurisdictions. They needed some flexibility to adjust it according to their local circumstances. And it's a fine balance. Paul, did you want to?
Yeah, I mean, I think, one of the things is you've got to tailor your response to your setting. So yep. Singapore is a big crowded urban city with many, people coming in from all over the world. And I think that's one of the big lessons that we've learned. It worked well at the beginning, it didn't work so well in the middle, and now it's gone back to working well again. There is a question from the chat, I think, in the Q&A. There are a couple of questions out there.
Yeah, we've got 2 there. The first is, will the new vaccine give an immediate effect and elimination of COVID-19 virus and change our strategy to fight the virus? Who'd like to say something about that?
Well, I can start. I have to declare a conflict of interest. I just signed off on a clinical trial we're going to do, not on one of these 2 new vaccines, but on a competitor. But I think that, ultimately a vaccine is going to make a huge difference. And this has happened before. It's happened with the polio outbreaks in the 1950s, where we had rollout of the Sabin vaccine in Singapore. And that really essentially almost eliminated polio within a couple of years. in the face of these massive outbreaks in a very crowded Asian city. So I think there is a precedent for vaccines coming in early in an outbreak and making a difference. And what's encouraging is that this is a completely new technology. And I was originally very skeptical. In fact, when the authorities asked me about it, I said, look, we've got 100-year-old technology, or we've got these new technologies, and the 100-year-old technology seems to work. But these new technologies are very exciting. We haven't had new technologies since maybe the HPV vaccine or the hepatitis B recombinant vaccines. So I think this is going to make a huge difference. And the challenge for the world is to see how this can be rolled out globally.
Mm.
I think also it is going to, you're correct, Paul, it is going to make a significant difference. And what's impressed me is the consortia that have been brought together, countries investing as a group and supporting vaccine manufacturers and vaccine developers, and also agreeing to distribute the vaccine to poor resource countries as well, ensuring that there's distribution, because ultimately I believe there will be enough vaccine, and it's just the rollout strategy that's going to be important in terms of distributing it. And everyone's going to be clamoring for it early on so that economies can get moving again. But I think it's distribution is going to take time.
Mm. Lance, I might follow on with you with the next question, which is this: CDC recommends physical distancing of 2 meters, while WHO recommends 1 meter. And I've seen some places where it's 1.5 meters. So there's a little variation, but the question now is, we've seen this, what is now a very common mutation, this D to G mutation near the receptor binding site, and it possibly may have a higher transmissibility. Do you think that would or should affect our recommendations for distancing?
Well, I think recommendations for social distancing have varied. And of course, there are, as Paul has pointed out, the laboratory experiments that show how far the smaller droplets are transmitted when we cough, sneeze, and talk. But the relevant thing for transmission, even with these few super spreaders, is separation, isolation. And this is one of the reasons why I think in New Zealand we introduced the bubble concept that was developed as a way of communicating to the public to remain in your own bubble, stay in your own group, stay in your own family setting for the lockdown period, with older people restricting their contact with other bubbles, family bubbles. And I think it's simply isolation is the only way to control this virus. This social distancing of 1 meter or 2 meters, of course, as soon as you go out into the street or into the supermarket or whatever, it's incredibly difficult to maintain that distance, even if they've got the supermarket chains have markings on the floor and let certain number of people in. Certainly this 1 meter or 2 meters apart, if the virus does aerosolize, and obviously there are situations, as Paul has indicated, with people coming in and sitting in the same area that's that someone else has been that is contaminant, has an infection and is possibly a super spreader, then the virus is transmitted. So I think that it's understanding how this virus is transmitted is the primary issue, and if people have symptoms, then isolation is the first thing that's got to occur. Keeping the children home from school and not sending them off to school, and these sorts of measures it's being honest in a family setting or a group setting, so that you protect your fellow workers. There are, of course, issues around this with sick leave from a workplace and people having to go to work and what have you, which, but at the end of the day, it has worked in New Zealand, and so it is achievable.
Paul, did you want to comment on that?
Yeah, I mean, I think, you know, to be honest, this is one area where the clinician researchers have kind of dropped the ball. Theoretically, these questions should have been answered, you know, 6 months ago or 5 months ago. But the fact that we're still arguing about them, you know, suggests that, you know, we've been trying to set up these studies in Singapore, but now we've got fewer patients. So it's a good problem to have. But on the other hand, you know, we don't have the answers. And similarly, in Australia and New Zealand, you don't have enough patients to run this kind of studies. But I do think that, you know, the absence of such data means that we have to err on the side of caution, which is what we have to do. But at the same time, you've got to look at the unintended consequences. I just discovered last week that in Singapore, you still can't visit nursing homes. So you've got these old people who are really isolated. And, you know, they had someone from the Ministry of Health to go to one of our nursing homes, and these old people just tore into this person. And it was really, really hard. So so these are very tough questions. And right now we're basing our decisions on observational data, which, as I try to point out, is not perfect. So we really need some good quality data for the next time around at least.
And maybe I'll just add that the importance of the D to G mutation, we're really still waiting. It certainly seems to be more transmitted in some of the animal studies, but whether that will translate into significant difference in community spread, I don't know as yet. And I don't think it changes the messages.
No, I agree with that, David. I think a point to consider as well is that we have 4 seasonal coronaviruses circulating. And it is possible that these 4 coronaviruses evolved from along a similar path that the current COVID-19 or SARS coronavirus 2 has evolved from bats through an intermediary animal into humans. So what we would expect, as we see even with influenza, is the amelioration of the symptoms, and it adapts to circulation in humans and tends towards mild illness infections. And I suspect we're going to, it's going to be an interesting experience with mass vaccination against this particular virus to see what pressure it puts on the direction of evolution of the virus. And I think that's something we've just got to wait and see. I don't think we can predict what's happening. However, I would expect the virus to ameliorate rather than to cause more severe disease.
Thank you.
Yeah, I would agree with that. In fact, David Heyman gave a presentation where he argued that, you know, when bovine coronavirus crossed over as OC43, there's some speculation that it appeared at the end of the 19th century and it caused the pandemic at that time. But again, you know, that kind of virological archaeology is not easy to do.
I think we look through the history of influenza pandemics, and there are several periods where, like 2009 and now 2021, the 2 pandemics close together, which from our recent experience of influenza is unusual. So they could well have been relate to emergence of or pandemics caused by coronaviruses or other respiratory viruses for that matter.
Okay, we've got some more questions come through to us. One of them, the first is one of the most difficult issues, which is that we've got our public health measures in place, how do we strengthen the role of science in decision-making across government and into people's private lives throughout the current pandemic and the priorities that we will face in terms of those balances, and also the accuracy of information coming through in the social media, some from apparently very authoritative sources.
Yeah, can I take that one on?
Please.
You know, I get all these messages from friends and relatives, all kinds of conspiracy theories and, you know, purported cures for the coronavirus. And now the latest one is all these things about vaccine, how it's going to alter your DNA. And you know, some of them are really crazy. But I think, you know, what's happened is partly a result of the polarization of politics in the United States, and it's spilled over to the rest of the world. And so it's become very black and white, and you know, you're either with us or against us, that kind of thing. And I think the missing voice in this is actually the patient voice, and the patients and the scientists. You know, this just seems to be dominated by bloggers and social media influencers, and it's gone upside down. And you know, the analogy I would use is with the HIV pandemic. You know, the HIV pandemic burst onto the scene. There was huge amounts of controversy. There was all that stigma and discrimination and stuff that happened, you know, in the 1980s when HIV first appeared. But what happened was you had these patient advocacy groups, which were pretty, some of them were of course pretty extreme, and they used to go around trashing exhibition halls at ICAC and stuff like that. But you also got them driving changes in the way we did research. I mean, it's the first time we had surrogate markers being used as endpoints, because they said you couldn't wait for mortality. So viral load and stuff like that became acceptable clinical endpoints. They pushed the FDA to change the way they approve drugs. And at the same time, you got scientists who are good communicators, you know, people like David Ho and stuff like that, who were able to use phrases, you know, combination therapy became a drug cocktail. And so it was a combination of effective science communication together with, I think, involvement of the patient community. And, you know, we're looking to Australia, who supposedly is going to end HIV in the next few years. And nobody would have thought of that, you know, 20 years ago. So I think, you know, we've got to learn from some of the other viruses that we've dealt with in recent history.
Thank you. The next question, in terms of the studies on COVID-19, the question is, may I ask, is there any studies that have managed to determine the infectious dose of SARS-CoV-2?
I think now that I don't think there are any studies that answer that question directly at the present time. It is being discussed now that we have a vaccine and potentially can run human volunteer challenge studies, which will be required to answer that question. I think limited studies probably have been done in ferrets, and Paul, you may be more up to date with the literature on that, or other animals in terms of the infectious dose in those settings. But in humans, we don't know at this point.
Yeah, there's I was just trying to think back and do a quick search. There's a group from Singapore actually that have been doing primate studies, non-human primate studies, to try and set up some of these assays, and it's just completely escapes me. But they have worked out what they think is an infectious dose. Again, you know, there's some interesting studies looking at infectivity in terms of the CT values for patients. And this is a huge issue when it comes to de-isolating patients. And there's groups in Germany, there's groups in Singapore as well, which suggest that after day 8 or 9, you don't shed infectious virus. And they've looked at things like subgenomic RNA, and they've looked at, you know, and it seems to be pretty consistent that once the CT value goes above 32 or 35, you're not going to get live virus or culturable virus. I'm not a virologist, you two are, so you can tell me whether I'm completely off on that.
I think also from rhinovirus 16 human volunteer studies that I've been involved in, challenge studies, it's having individuals that have severe respiratory illnesses, severe colds, whom are the most efficient transmitters, which supposes they're shedding lots of virus. And I think this is another important aspect with regard to exposure to, well, what the infected dose is.
And there's certainly been a lot of attention to issues like sneezing and coughing and shouting and singing, all those sort of things that whether how much they contribute to the differences in risk of transmission, which then complicates social distancing measures as well, of course. But and in terms of the residual virus, yes, it's pretty consistent depending on your PCRs. If you get CTs above 30, it's very unusual to recover live virus. So certainly it seems to go away after about 8 to 10 days, with the exception possibly of people who progress to more severe disease. Now, next question. That was infectious dose. One of the audience has asked about what the potential is for the mRNA vaccine, because these are the first mRNA vaccines which will or that will have been used in human populations.
Yeah, I mean, I think I alluded to that just now. I was originally kind of skeptical as to whether the mRNA vaccines would work, because, you know, mRNA is very fragile, and it's but the two companies that seem to have got it to work, the vehicle seems to be able to transport it to the site where it needs to be transported intact, so it's able to generate the production of the relevant proteins. And you know, we've had subunit vaccines, we've had all kinds of, we've had recombinant vaccines. The HPV vaccine is a VLP vaccine. So, like I said, the clinical data from two completely different studies are remarkably concurrent, which suggests that this may work. The interesting thing, though, is the question as to how long the protection is going to last. And in one of the correspondence letters that followed the first publication in the New England Journal of the phase 1 and phase 2 data of the Moderna vaccine, the comment was made that, you know, if you continue producing the protein, you may end up desensitizing the individual. But I talked to an immunologist about it, and his point was, look, if you're desensitized, then you may be colonized with the virus, but you're not going to get sick. You know, if you keep getting exposed to the protein, and that's an interesting way of looking at it. The other question, though, is whether the dendritic cell is going to stop producing the protein. And my take on it is that, you know, so what if it does? Because I see this vaccine as something that's got a lot of use in travelers, or it's got a lot of use in an epidemic situation. Because what we've seen is this virus, you know, the super spreading situation where you get, you know, one guard getting out of a quarantine center and just spreading it to everyone around him or her. And so if you had a vaccine that had protection for 3 to 6 months, you know, it's still going to be useful in specific targeted situations. And I think we shouldn't write it off completely. Just even if you see, you know, protection waning. And again, this whole question of protection is another one, because, you know, antibody titers we know have been waning for COVID-19, for SARS-CoV-2, but that happens with every other virus. The antibody titers do wane over time. But there's a group in Singapore looking at the T-cell responses, and those have been pretty encouraging. In fact, we had a bunch of people with SARS in 2003. You know, a lot of them were healthcare workers, so they called us up and they volunteered to donate their blood and plasma and stuff like that, which is really nice. But when we took their T cells and stimulated them, we found that they were able to neutralize SARS-CoV-2. So there is some hope that you're going to get some degree of long-lasting immunity, but again, time will tell.
And it's true that the other vaccines coming through, the subunit vaccines, you'll only see the virus, that bit of the virus once, to trigger your immune response as well. Can I will get, there's a question about salivary testing, so you can prepare yourself for that, Lance, but because of this follows on from that particular issue. So I wanted to skip to this question about, can there be reinfection with SARS-CoV-2 after you've had it and have recovered from it? So Paul, I might get you to answer that, and then Lance.
Yeah, so there have been at least, I think, 6 well-documented reinfections where they've had whole genome sequencing and you've identified different strains of the virus. The first one that was reported out of Hong Kong is very intriguing because the individual was infected with the virus but did not mount an antibody response. And he had a mild to moderate illness. And then a few months later, he was infected for a second time. And this time he seroconverted, but he had a very mild and actually he was asymptomatic, practically asymptomatic second time round. So, so there is something about this guy. And then there was another case, I can't remember whether it was in Europe or North America, where you had an immunocompromised patient who had been on one of these monoclonals, and he had a reinfection with a different strain. So it is clear that reinfection can occur, but we've had millions of people infected and relatively few. And I've been asking around, and I haven't found anyone. I've asked friends in Hong Kong or Canada whether anyone infected with SARS has been infected with SARS-CoV-2. And again, I guess there were relatively few cases in Hong Kong, Canada, and Singapore. So, so we don't know. But I think it's intriguing, the possibility that you might indeed be protected if you mounted a good immune response and you survived SARS. And similarly with SARS-CoV-2. But remember, even for viruses like chickenpox, you do get a handful of individuals who get a second documented episode of chickenpox. And I've heard various theories about that, about different strains of varicella. And I've asked Judy Brewer in London about it, and she's given her own theories. But there are going to be some individuals, I think, who might get reinfected, but I think it's going to be a really small minority. Over.
Yes, I agree with that, Paul, and I'm sure we would have seen a greater number of cases now with the spread of the virus of recurrent or second infections. And there's a note in scientific literature today about suggesting that perhaps if this in the context of vaccination, we're unlikely to see second infections occurring within 6 months after receiving the vaccine. But of course, it's early days and the scientific evidence isn't available yet. As regards vaccines, David, I'd just like to bring us back to the fact that influenza vaccine is far less effective than what the initial data with this SARS coronavirus 2 vaccine is suggesting at the present time. I'd just like to sort of bring that put that into context. And certainly in the older people, we're using the vaccine to ameliorate the more severe consequences of infection, not prevent infection.
Well, the obvious question then is, will this lead to better flu vaccines? Are we learning more about the technology now that's going to help us with influenza vaccination as well?
Undoubtedly, it will stimulate research on that. And Paul, you may be familiar with the RNA aspects, but with regard to influenza, I don't think that's certainly the DNA vaccines haven't been very successful. We've heard very little about the RNA aspect.
Yeah, I think they never really took off, but now they'll probably get a second win because a lot of the intermediate steps in the technology have been solved. through the efforts with this SARS-CoV-2 vaccine. So there is a chance that we might get an influenza mRNA vaccine.
And we know the cold chain is likely to be challenged in a number of countries for the RNA vaccines as well. Lance, I warned you, there's a question here about saliva as a primary sample for COVID testing. Bill?
Yeah, and of course some countries are using saliva for testing, and I think there are two issues here. One, first, the saliva is usually positive when nasopharyngeal samples secretions are positive, but the titer of virus present in saliva is lower. So it's just a slightly less sensitive way of testing for the virus. However, the other aspect that's important, when you're mass sampling people, and perhaps in poor resource countries, then perhaps saliva is an easier specimen to collect and to test. I think our approach at the present time is to be, certainly in New Zealand, has been to use the most sensitive assay and sample for detection of the virus in clinical cases. And so this use of saliva samples has not been popular. The other aspect, of course, if you don't have swabs or access to nasopharyngeal swabs, well then saliva is a second sample of choice.
All of you?
Well, you know, all my patients, in the beginning when we had, we used to swab patients every day, they hated it. They hated the nasopharyngeal swabs. And when the first news came out about saliva, they kept asking me, can we do saliva? And I said, you know, we haven't validated it. We don't know that it's going to work. So I think there is potential for saliva, but it's going to take a while. Right now, the current saliva-based assays, to my mind, are just not good enough.
Mm. Yeah, certainly with us, some comparisons we've done, it's consistently about 10 to 100-fold less sensitive than swabs, but that might be okay in those very high, the period of time when people should be shedding high amounts of virus. So it would be interesting to see. That's the end of those questions. And I just, and I think we're just about on time to finish up at the moment. And thank you for two wonderful presentations, and thank you to the audience for their questions. And of course, to APACI, who this is under the auspices of, and to our partner Praxhub for hosting the event. And I'd like to also leave it on one of the messages you had at the end of your slides, Paul, that, you know, we all concentrate on what we're doing in our country or our local level to control this, and that's important. But we do need to remember it's an international problem, and we do need to make sure that we get equitable access to vaccines and antivirals as they become available. So thank you for that, and I'll say good night.